Hi guys, it's Professor Costa and we're back with impaired cerebral perfusion, and this is acute phase part 3. So the goal for stroke treatment in the acute phase, right? We want to preserve life and we want to prevent further brain damage and decrease disabilities. Really, we want these people to have a realistic expectation, but we also want to try and preserve as much function as we can. So for an ischemic stroke acute care, and this is from the American Heart Association and the American Stroke Association, we want to get that chain of survival, right? Rapid identification of a stroke, immediate EMS dispatch and transportation to the nearest stroke center, and rapid diagnosis and treatment in the hospital. So we are really going to manage our ABCs. So we want to monitor and treat blood pressure, monitor fluid and electrolytes, assess for increased intracranial pressure. Some patients with a severe enough stroke may need an advanced airway. So are they having difficulty breathing or maintaining normal respirations? That's what I mean by ABCs, all right? So the standard of care for an ischemic stroke right now is IV TPA within 4.5 hours of stroke onset and a mechanical thrombectomy that's going to VIR for patients with a large vessel occlusion within 6 hours of stroke onset. Okay, and that's obviously if they're a candidate for either therapy. So factors influencing treatment. So we know that we have a limited time frame, and originally it was 3 hours. Now we're saying 4.5 hours from the last known well, because the treatment with TPA is not risk-free. If we go beyond that initial time period, there's going to be swelling and increased risks of bleeding associated with TPA administration. So we could end up making a bad situation even worse. So clinical deficits, how pronounced is the deficit? Again, TPA is not without risks, okay? The site of occlusion and the infarct core, right? How big of an area are we looking at in terms of actual infarction? So what do we mean by that? So core and penumbra. So the penumbra is the tissue that's at risk, but is still salvageable, right? But right now isn't functioning. The core is the area that's already dead. It's irreversibly damaged, the tissue's gone, and we want to keep that core as small as possible. So we want to treat it early and recover as much of the penumbra as we can. We don't want to wait until it's completely overtaken that area and we have a huge area of brain that's dead. These two patients can have identical physical exams, remember, because the tissue in the penumbra is not functioning, but it's still salvageable, right? So that's why we need that diagnostic imaging. We need the CT or the MRI to tell them apart. So options for treatment of an elbow. The first option, and you've all heard of this isn't new material, is Alteplase, which is RTPA. And it's the only one approved. It's the actual clot buster. And it's been used for over 20 years, which just blows my mind, realizing how old I am. And that time is of essence. We have that 4.5 hour window since their last known well. And then the newer treatment, which isn't even that new anymore, it's been around for a couple years now, is mechanical thrombectomy. So you go to VIR and they thread a catheter in through a large vessel and they literally go up and they snake that thrombus out, right? So that's direct removal of a clot using a special device, okay? And best practice, if they're a candidate for both, they get both. Fibrinolytic therapy for ischemic stroke is that TPA, dissolves the clot, reopens the occluded vessel. This works best if it's given early, but they have extended the time to 4.5 hours. Here are some exclusion criteria. Now, these are criteria. There's no hard, like the physician, the neurologist is the person that's going to make that decision. But some things that may exclude them would be if they're over age 80. Again, that's questionable. If you had a very high functioning, well patient otherwise, then they may still receive it. If they're already on anticoagulation therapy, okay? If the image shows that 1/3 of the brain tissue involved is supplied by the MCA, or if they have an NIH stroke skill score of greater than 25, or a prior history of stroke and diabetes. They may be excluded because the risk of bleed is so much higher with them that we may do more harm than good. But again, the neurologist, the physician, would be the one ultimately responsible for deciding whether or not TPA was administered. And the patient and their family as well. There are patients that would absolutely not, given the risks that are included, may opt not to receive it. So this would be something that the family and the patient would be part of the decision-making process. So administration of TPA and how do we care for them afterwards? So Alteplase, it's 0.9 milligrams per kilogram with a max dose of 90 milligrams delivered over 1 hour, right? So 10% is administered as a bolus over a minute, and the rest is delivered as a drip over an hour. So, and then it's followed by 50 milliliters of normal saline. So we're going to give them that bolus, and then we're going to follow it up with 50 milliliters of normal saline, right? And that gets followed at the same rate of the TPA. So during the infusion, all right, so we're hopefully, the word is hopefully reperfusing parts of this person's brain, right? So we could get changes, and they could be good changes or they could be bad changes. So we want to do the modified NIH stroke scale or mini version and vital signs every 15 minutes, right? During the infusion, we want to make sure we are frequently monitoring this client, all right? Post TPA, we're going to do, and I want you to know this, okay? We want you to monitor their NIH stroke scale and vital signs every 15 minutes for 1 hour, every 30 minutes for 6 hours, and every hour for 16 hours. You really have to let the nurse leaving, or coming in, you guys have to be on the same page. You have to tell during your handoff where you were in this process. And the reason I want you to know this is from one of our partnering facilities. They had an issue with this not being done on the correct time frame, and they had a poor outcome. Somebody was not assessing when they should have been, and we had a poor outcome, something that was missed. So our partnering facility asked us to make sure that you guys know this, leaving school, that you understand that this is their current protocol and really is good best practice. So post-TPA administration, if there is a change in the neurologic status, you need to do not the modified shorter one, but you need to do a full NIH stroke scale, right? We have to be super duper careful with blood pressure management. We do not want these patients becoming super hypertensive. And I don't mean like managing a blood pressure above 140. In many cases, there are strict protocols, and they may allow for some higher blood pressures, but obviously, if we have a blood pressure of like 220 over 110, that's a patient that's very hypertensive, and that's going to increase their risk of bleed. So you're going to follow the agency protocol. They're going to give you a number, and you're going to watch and make sure that the patient has a blood pressure that is managed per your facility's protocol, okay? And we want to manage glycemic control too, which is very important. We want to make sure that the brain that is being reperfused has adequate glucose, but not too much, and has good insulin coverage so that we have a working brain. Okay. So a stent retriever, this is where we, roto-rooter it out. We literally go in and we thread this in through a catheter. So similar to cardiac stent, it's placed through a catheter introduced in the groin or radial artery. It's got to be a big vessel. They thread the catheter up to the area of occlusion. The stent is deployed. See, it's kind of like a mesh, and it wraps it, gets all in there, and you can actually pull the clot right out, right? So the potential complications, I'm thrown back to me. Hemorrhagic conversion of an ischemic stroke. So obviously we can open a vessel up too much. We can actually dissect the vessel and then cause a hemorrhagic, right? We can have cerebral hemorrhage. We can have increased intracranial pressure, vessel perforation, all those things we can accidentally do. We can cause vasospasm. So we can irritate the lining of that vessel, and then it clamps shut, we can cause reocclusion of the cerebral vessel. So we've already opened it up, and now we go poking holes in there, and we stir up more than we, and we can actually reocclude the vessel. We can have a hematoma at the site of insertion. Remember, this is usually alongside TPA, so they're going to have limited ability to clot. And now we're placing in a large cordis. That's the introducer of the catheter. That's pretty big. And so we can have a hematoma at the site, or a pseudoaneurysm at the site of insertion. We can dissect part of that vessel, and then we can end up with a pseudoaneurysm. So the modified NIH stroke scale that's used with a neuroassessment post-TPA or thrombectomy. So this is that one we're doing every 15 minutes or, for the first hour, and then yada, yada, yada on that other slide. So level of consciousness, visual fields, facial droop, speech or aphasia, arm drift. So you're going to test each arm separately, okay, and have them hold their arm out for 10 seconds, and a leg drift. And again, we're going to test each leg separately and have them hold their leg out for 5 seconds. Post-thrombectomy care. So obviously a neurologic exam, the modified NIH stroke scale, vital signs, and that's done at the same frequency as the post-TPA treatment, right? And then in addition to above, here's the added part of this. We're worried about neurologic status, but we also want to make sure that we haven't interrupted perfusion to the limb where we've inserted the catheter. Okay, so pulses and insertion site are also included. So peripheral pulses. So if it's a femoral insertion site, we want to make sure that that leg is still perfused. So peripheral pulses, color of the skin, temperature of the affected extremity. We want to watch for a sign of a hematoma or a pseudoaneurysm. So we want to make sure that and bleeding as well. Patients can bleed out from these pretty quickly too. So we're going to monitor that insertion site very, very carefully, and we're going to make sure that the limb where we inserted the cordis is also perfused. We don't want them to lose a leg, save the brain and lose a leg, which would be a horrible outcome. I mean, I'd rather save the brain, but if we can save the leg, we want to do that too. So it is critical that all of the checks, you need to do a thorough assessment, neuro, vital signs in the site are done on time and documented correctly. Okay, why am I reiterating this? Because this is what happened at Rhode Island Hospital. They had a sentinel event. All right, so forgetting any of these requirements at any interval will mean that the follow-up care is out of compliance, and this could severely compromise the patient. All right. Make sure you report when these checks are due during handoff at the end of your shift. And that is part of continuity of care. That is your responsibility as the nurse, that you reported off that you were still doing, for instance, your 30-minute checks. All right, exactly where you are, how many are left to do, when the procedure was done, and the current response. So core measures for ischemic stroke care would be VTE prophylaxis. These patients may not be moving around well. Antithrombotic therapy at discharge. That they're discharged on anticoagulation if they have AFib or aflutter. Thrombolytic prescription for qualifying patients. That their antithrombotic prescriptions are evaluated by the end of the hospitalization. That they're placed on a statin at discharge. That we've documented all of the stroke education, and it's a lot. And then we want to assess them for rehabilitation. Remember that, if we've gotten to them early enough, they may have areas of their brain that are healing and are able to come back. And we would, need to make sure that they get into a good rehab facility. If we have areas that are infarcted and that aren't coming back, we want to maximize their quality of life following this event and get them rehabbed and, relearning how to do things.